Good morning, everyone. My name is Kelsey Bergfeld. I'm the Director of Advocates for Ohio's Future. Thank you so much for joining our webinar on this beautiful Friday morning. We are here today to talk about some process here with the budget, moving on through the General Assembly right now. The budget is being heard by the Senate. It is broken out into many different Senate kind of subcommittees, track committees. They decided to call them track committees, this General Assembly, just to spice it up. So lots of hearings happening in the last 2 weeks as well as this coming week. As far as I know, this will be the last week of hearings on the budget in those subcommittees, looking to maybe move to full Senate finance the second week of May. So lots of great action, lots of things to talk about today. We're really excited also to have 2 AOF members join us today. We have Soley Hernandez from the Ohio Council joining us, as well as Jordan Ballinger, kind of repping 2 different organizations today, Disability Rights Ohio, as well as one of the leaders of the Home and Community-Based Services Coalition, of which AOF is a proud member. So we will get to their presentations in just a moment, but wanted to make sure that we have a clear idea of what's happening in specifically Senate Health Committee coming up next week. Lots of action there. So coming up next week, we have some big departments will be testifying. On Tuesday, we will be hearing from the Department of Health, excuse me, man, not enough coffee yet today. The Department of Jobs and Family Services will be testifying on Tuesday starting at 2:00 p.m. There's also a number of panels will be testifying later that day, maybe a late night in Senate Health Committee. So I'm excited for leaders of Advocates for Ohio's Future to be testifying as a panel before the committee. I heard we'll also have a food security panel led by our members at the Ohio Association of Food Banks, as well as a child care panel happening on Tuesday evening. So make sure you tune in. Of course, all hearings will be live and broadcasted on the ohiochannel.org. Coming up on Wednesday in Senate Health, we'll be hearing from the Department of Medicaid as well as the Department of Aging. And then that last day on Thursday will be kind of that catch-all, last chance to testify before the subcommittee. As always, process for testifying. If you do plan to testify, make sure you get your witness slip in at least 24 hours before committee starts. They are really stringent about that. So make sure you follow the rules. I know it's tough to bust out that testimony really, really quickly, but those are the rules we have to follow. Also make sure that if you choose to submit written testimony or comments to go along with appearing in person, the deadline for that is also 24 hours in advance. So keep that in mind. If you do need a copy of the witness slip, or if you need a contact to make sure you're sending your testimony to the correct person, please feel free to email me directly. I'll add my email into the chat here in just a moment. Will all of these be on the Ohio channel? Yes, they will be at ohiochannel.org. They'll be live, and then you can also go back and watch them in the archive once that they've concluded. So they'll be live at the time. It's always fun to watch your friends testify live and cheer them on from afar these days. Very quickly, also wanted to give a quick preview of our next webinar. So 2 weeks from today, on Friday, May 14th, AOF is going to have, we're going to change up our format a little bit. We're going to be having a special edition of our webinar series. We'll be having probably 12 to 15 of our member organizations test or talk about in a really rapid fire round robin style presentation on the American Rescue Plan. So it is a monster of a bill that was passed by the federal government a few months ago. There's a ton of additional resources, different funding streams coming into the state. I know I have had trouble kind of as one person wrapping my head around everything that's coming into the state, really the deadlines and the timelines for spending those dollars, what the authority is to spend those dollars, what they're really intended to be used for. So we will be inviting 15, I think, of our member organizations to come and speak. I think you might see Jordan and Soley. We'll see. We'll see if they'll be so kind to help join us that day, really making sure that we give our stakeholders, all of our audience, as well as the General Assembly, legislative staff, leaders, a chance to hear our presentation, to help us together make sense of all this money coming into Ohio and make sure we really make the most of it. We know that we saw in the last recession, we saw some federal dollars not spent either appropriately or at the right time. And we did send a whole bunch of money back to the federal government because we didn't have a great plan for it. So we are here to make sure that we're thinking about that way far in advance, and that we make sure that those dollars are used in a timely fashion, and they can do the most good for Ohioans that really need help over, from the still recovering from the pandemic and moving forward and coming back as a even stronger Ohio. So with that said, I will go ahead and pass it over to Soley. Excited to hear your presentation, Soley. Whenever you are ready, take it away.
Great. Thank you, Kelsey, and thank you for having us here today. So I'm Soley Hernandez. I'm an associate director with the Ohio Council of Behavioral Health and Family Services Providers, and I'm going to touch on kind of the behavioral health budget priorities. So just a little background on the Ohio Council in case you aren't familiar with us. So we go by an abbreviated version of our name because it is a mouthful, but we are a statewide trade association representing over 150 community-based mental health and addiction services providers throughout the state of Ohio. Our members offer services to children, adults, families through a variety of different modalities: prevention, school-based intervention, treatment, and recovery support services. And our goal is really to pursue effective policy solutions that address both the overdose epidemic and meet the rising demand of community-based mental health and addiction treatment services so that everyone in Ohio can experience health, recovery, and wellness. So overall, we were very pleased with the introduced budget. It continues key initiatives and investments aimed at improving the health and well-being of Ohio's children and families. There really is expanding access to mental health and addiction treatment services, and looking at advancing some really strategic and crucial improvements to the Ohio Medicaid managed care program. So in terms of the mental health and addiction services budget, the governor's proposed budget really responded in a number of ways to the mental health and addiction crisis that we're seeing in our state currently. We were very pleased to see the budget proposal continued the investment in behavioral health services across the full continuum of care. So that looks like the prevention services I mentioned to early intervention, treatment, and recovery supports. And we really are in strong support of the continued investment in crisis services and crisis stabilization centers across the state. There were new resources also that are aimed at supporting enhanced care coordination for adults with severe and persistent mental illness. Additionally, there's criminal justice and specialized docket supports that were expanded, and then also funding for recovery housing. And then the Department of Medicaid's budget, we are in support of the department's ongoing implementation of their reimagined managed care reprocurement. So this has been going on for a while now, but we're starting to see pieces move, and it's a key initiative for behavioral health providers. Really specifically, some of the key things for behavioral health in the Department of Medicaid is the Ohio RISE program, which offers service enhancements for kids with complex behavioral health needs. There's also funding for behavioral health care coordination, enhanced transparency for managed care and accountability measures with the managed care plans, and additionally reduced administrative burdens for providers through some of the changes with the contract for the managed care plans. And really, we very much appreciate the focus that the Department of Medicaid has had on patient experience and provider partnership versus just the business of managed care. Additionally, with the Department of Medicaid, and it falls under the Department of Mental Health a little too in terms of policy, but really the continuation of paying for telehealth services under Medicaid throughout the COVID-19 emergency and ongoing has really been key for access to behavioral health services. And the department actually released some data earlier, actually, I think it was last year, that between March 2020 and August 2020, they saw over 627,000 members use telehealth services for a total of about 2.6 million claims. And of those claims, nearly half were for behavioral health services. So behavioral health services providers really quickly pivoted to be able to provide telehealth services. Not a lot of organizations were doing that prior to the pandemic, and it has been very important for providers to be able to do that, and also for Ohioans to be able to receive services by telehealth. And the Department of Education. So the Ohio Council supports the Department of Education's budget proposal of the $1.1 billion in student wellness and success funding as it was introduced. So these resources really have greatly expanded access to care for school-based health services and behavioral health services. And they're critically important as we continue to navigate this pandemic. A number of our members have strong relationships with schools. They are providing, prevention, early intervention, and treatment services in schools. We've seen some changes from the proposed budget with these funds specifically. So the House Bill 110 really kind of proposed wrapping the funds into the school funding formula under what is called the Disadvantaged Pupil Aid Impact Funds. And that really will kind of dilute the use of those funds. So these school wellness and success funds are really targeted to help with specific health initiatives, behavioral health being one of them. And a high percentage of the current, of the funds that exist currently have been used for behavioral health services. So we actually, in our budget asks with the Senate, have asked them to restore the student wellness and success funds back to how it was introduced in the governor's budget initially, because we see these funds as crucial for being able to meet the needs of all students in schools. So these are funds that can be used for all students. And that's an important thing that we focus on, is that behavioral health is for everyone and should be for everyone. And those prevention services in schools are key. Additionally, we had an ask that touches on the behavioral health workforce. So unfortunately, we're seeing a workforce shortage across the state in all levels of positions in behavioral health agencies. So we did make a recommendation to enhance funding to support and promote recruiting and retention of professionals in the behavioral health workforce. The Department of Mental Health and Addiction Services does have funding for workforce initiatives in its budget. However, it's not substantial, and it really has been limited one-time funding. So behavioral health providers have been able to access it sometimes, but you get it for a year, and so you can't really build a sustained program for successful employee recruitment and retention without ongoing funds. So our ask was to increase the funding initiative by $5 million annually to support workforce development initiatives of behavioral health provider organizations that are certified by the department, so they can develop and sustain these types of programs. And so that ask was also supported but changed in House Bill 110. So they did change our $5 million annually to $2.5 million. And that's really kind of the high level overview. I am always happy to, answer questions if we have time for that later. I don't want to take up all the time, but also my email is here if you want to reach out to me by email as well.
And thank you so much, Soley. So we are going to allow Jordan to get his slides up. Let's see, you should have that authority here, Jordan. And Soley, that was really interesting. So good news, especially on the workforce front, there was some additional money added for those initiatives. What are your thoughts on that being just one-time money? We know that the workforce struggle has been ongoing for many years in the behavioral health space. Any thoughts on how we can make that really kind of substantial change? I know 5 million is the ask, but continued support is so crucial.
Yeah, certainly. And, we really are hoping that this can kind of over the biennium help, but show outcomes of being able to really support the workforce and recruit more people. And if we can offer incentives like tuition reimbursement.
Great. Solely, thank you so much. Jordan, your slides are live and ready to go. So whenever you're ready, please take.
Awesome. Thank you, Kelsey, and thank you, AOF, for having me on today. I'm going to be doing a little bit of a dual presentation for both Disability Rights Ohio and the Ohio HCBS Coalition. Before I kind of get started into our budget asks or our priorities, I want to give just a little bit of a background as to who the coalition is and kind of how we started and why we exist. We are a new coalition. We just formed officially in October of last year, and we really were formed because of the pandemic and moving into this current budget cycle. So Disability Rights Ohio, for those of you who don't know, we are the protection and advocacy system and the client assistance program for people with disabilities in Ohio. There's one of us in every state and territory in the United States. We were created by an act of Congress back in the 70s to really investigate instances of abuse and neglect in institutions that were housing individuals with disabilities. Our mission is to advocate for the human, civil, and legal rights of people with disabilities in Ohio. I'm not going to read the vision, it's very long, but there's the vision for you as well. For the Ohio HCBS Coalition, our mission is to advocate for a strong HCBS system that provides all Ohioans the opportunity to thrive and stay connected and engaged in their homes and communities. So a little bit of an overview of the HCBS system here in Ohio. The system here has been really historically underfunded for a large part of the history here that the HCBS system has existed in the state. Ohio was kind of on the forefront in the 60s when we created our local county boards of developmental disabilities and behavioral health. Since then, though, in 1988, we did our Mental Health Act, which really kind of paved the way for a new community-based system in the state, but we've really not, since the act was passed, made any major changes or provided the needed funding to any of the HCBS systems to provide quality supports to people with disabilities in their homes and communities. Soley kind of mentioned a workforce in the mental health space. The same kind of issue persists across the board for all of our service systems, specifically for DD and ODM and ODA administered waivers. Direct care workforce is greatly underpaid. And because of this, it stresses the system capacity and it forces a lot of our individuals into institutions to receive care just because they don't have access to the workforce in their community. Additionally, COVID has exacerbated issues to access with HCBS supports, and it has also put those in institutions at a higher risk. At the founding of the coalition, about 60% of deaths were in long-term care facilities. I think now the total number of deaths is around 40% in long-term care facilities, which is still a large percentage of the deaths due to COVID-19. Just a little bit of background on the direct care workforce, and I'll give you a little context as to why I'm giving this later on. 42% of our direct care workforce are BIPOC individuals, Black, Indigenous, people of color, whereas they represent about 18% of the total Ohio population. So our direct care workforce, is disproportionately impacted, and BIPOC individuals are disproportionately impacted by any increases or no increases made to their wages. Their median hourly wages currently are $12.10 an hour, or around $16,000 annually. It's estimated that the lowest wage for an Ohioan to meet their basic needs is $13, a little over $13 an hour. So these individuals who are providing care, supports, and services to people with disabilities and older adults are just really unable to kind of make their own ends meet. And because of that, a lot of them, 53%, receive some kind of public assistance, and about 39% are enrolled in the Medicaid program. So not only are they being paid by the department to provide services to people with disabilities and older adults, but they're also on the program for their own health needs. Low wages also tend to push these workers into other industries. For instance, retail workers have a higher median hourly wage of $12.14. Office clerks have an hourly wage of $16.37. And Costco, I think just this year, announced that it was going to start paying their workers initially as they come through the front door at $16 an hour. So it's really hard to compete with these other industries. I think all of these industries, they deserve to be paid this kind of salary, but also people who are providing services to people with disabilities should be paid enough money to at least live independently as well. Additionally, the need for this workforce is expected to increase by 34% in the next 10 years, making it one of the largest growing professions in the US. So because of all of this, because of the impact on HCBS, because of the workforce and the stress that the system has had on the workforce for years and years, our advocacy goals as Disability Rights Ohio was to maintain and expand HCBS, ensure an increase in provider rates and wages. And for us, what we saw during the pandemic was there wasn't really a good, concise way to ensure that care rationing in our hospitals was not being done based on disability. So we really wanted to see a hospital licensure program so that there was a centralized way for us to advocate to ensure that hospitals weren't rationing care for people with disabilities. So what this led to, kind of within the realms of AOF, back in May, the coalition itself sent a letter to the administration calling for them to fully support HCBS system. A number of us within the coalition kind of helped work on drafting this letter. Because of this letter, this same kind of group of individuals got together and decided that a path forward, an effective path, an effective strategy would be to establish some kind of coalition that would be a force in the state budget to really advocate for the same kinds of things we were saying in the AOF letter. So in August, we sent a letter to Governor DeWine. It was not a coalition officially, but about 50 organizations and individuals signed this letter. And by October, all of those groups had officially formed to make what is now known as the Ohio HCBS Coalition. Along with that, we created a number of goals, objectives, talking points, everything that we would need to help support advocacy moving forward. The core group that kind of helps steer this committee or this coalition is ourselves, Disability Rights Ohio, the AAAs, the Ohio Statewide Independent Living Council, the Ohio Council for Home Care and Hospice, and the DD Council. Most of those groups, all except I think the DD Council, are actually members of Advocates for Ohio's Future. As of today, the coalition comprises of more than 100 organizations and individuals. Collectively, the group identified going into the budget one goal and then 4 ways of obtaining that goal. So prioritizing efforts to reinforce and grow HCBS through expanding transitions, identifying those most at risk, preventing a reduction in individual services, and supporting and bolstering provider workforce capacity. As the budget kind of came out and we were looking at honing our messaging and talking points, we centered around 3 main points going into the budget. This was closer to when Governor DeWine submitted his proposal, which included increased wages for home care providers, increased transitions from institutions to the community, and increase access to quality providers and expand housing. Governor DeWine then submitted his budget, and I think the coalition was relatively pleased overall. There was a large focus from the many fact sheets that were put out, just from what Governor DeWine was also saying in public. There was a focus on home and community-based services and supports in this budget. However, the coalition felt that although there was a lot being done, there still needed to be more. So Governor DeWine focused on HCBS and the need to shift funding. The Department of Medicaid kind of released a number of documents, including one that showed the shift in percentages of people who are receiving services either in long-term care facilities or HCBS. And since 2007, it's kind of shifted dramatically. In 2007, over 50% were in long-term care, under 50% were in HCBS. In 2021, it's estimated over 60% are receiving services in HCBS and around 40 in long-term care. However, the funding has not met that shift. There is still a large chunk of dollars from the state going to long-term care facilities, but the money has not followed individuals into the community, though a large share has moved out into community-based services. The governor reiterated a focus on implementing the Ohio RISE program, as Soley indicated. There was an increase in provider rates by 4% in the first year of the biennium. They established a hospital licensure program. They established an $11 million program for intensive case management for people with mental health labels, as Soley kind of indicated or talked about as well. The student success and wellness funding was expanded to the $1.1 billion. That's more of a DRO priority, which I'll get to. There was a creation of the nursing home bed buyback program. There was an elimination of statutory quality incentive payments for nursing homes. And the one thing the DRO, has been trying to advocate for a number of years is the full drawdown of the federal match for vocational rehabilitation services through the Department of Ohioans with Opportunities for Ohioans with Disabilities. So these are kind of services that help individuals with disabilities attain and retain employment. We have not, as a state, pulled down our full federal match in a number of years. So DRO was hoping to see that in this budget. Because of Governor DeWine's proposal, the coalition kind of shifted our focus into one specific ask, which was pushing for an increase in rates 5% in each year of the biennium. That would be 1 additional percent the first year and 5% in the second year. We also were advocating for the inclusion of language that would tie these increased investments to wage increases for our direct care workforce. Coalition, its members submitted testimony, met with members to advocate for this amendment. Members in the subcommittee for HHS seemed incredibly supportive, and there was really no indication that we would not be getting this increase in the substitute version of the bill. For Disability Rights Ohio, obviously we supported the coalition's asks. We wanted to see the maintenance of the nursing home bed buyback program, which was $50 million to basically reduce the capacity. They estimated around 20% or 11,000 beds were currently underutilized, and the state would be incentivizing nursing homes to eliminate those beds so that the state was not paying a portion of the beds that were in those nursing facilities. We were also advocating that the dollars saved from the bed buyback program be reinvested into the HCBS system. We were really pleased to see the licensure program for hospitals and ODH's proposed budget, and we wanted to see a maintenance of that program. We did want to see an increase in investments into the multi-system adults, as it was indicated, beyond $11 million. As I mentioned at the top, the mental health system really has not been effectively funded since it was really created or since the 88 Act. And there are a lot of issues that persist in that system, including lack of capacity to provide services to individuals in their community, which often leads to homelessness, individuals being jailed or in prison, or institutionalized in some capacity, either through nursing homes or state psych hospitals, et cetera. And so the state really isn't supporting people in their community. And so we really want to see additional dollars invested into that service system. We wanted to see an increased investment in the multi-system youth and ensure implementation of the Ohio RISE program to prevent custody relinquishment. We're incredibly excited about this program. So I know Soley mentioned it in her presentation. So we're really excited to see what this program looks like as it rolls out. So we pushed that a little bit in our advocacy as well. And then, of course, we wanted to pull the state to pull its full federal drawdown, which would be about $6 million in each year of the biennium for GRF, which would pull a total of $48 million total over the biennium. In the House passed version of the budget, they actually did not give us the 5% increase that we had requested as a coalition. They did maintain the 4% rate increase that Governor DeWine's budget proposed. They did mostly maintain the hospital licensure program. There were some changes to it. But overall, the state is still, at least from the House's version, going to implement that program. They maintain the $11 million for care coordination for people with mental health labels. The one issue we had, one of the issues we had, was the elimination of the student success and wellness funding for Disability Rights Ohio. This funding really helps students with disabilities. It's a large chunk of money that is incredibly flexible. And the most recent report showed that around, I think around 66%, if I'm wrong, anyone on this call, please feel free to correct me, went to mental health services in schools. And that is incredibly important. That helps support students with disabilities so that they are able to continue on with their education, be supported in their schools. They shifted, as Soley said, this into kind of this total funding formula. However, the issue is the amount of money that was in this standalone program is not going to be the same, and it's not going to impact the same kinds of schools. So this was funding given to pretty much every school district and was very flexible in its use. Now it's going to be more narrowed and targeted, and it's not going to have the same kind of impact on our students with disabilities. They did add a new school funding formula, which included the elimination of the wellness funding. The House eliminated the nursing home bed buyback program. They reestablished the quality incentive payments for nursing homes. They did, however, provide $5 million in each year of the biennium for adult day services and the developmental disabilities budget, which we're really happy to see. However, they still did not pull down the full VR match. So moving forward, what the coalition is going to be advocating for in the Senate is the inclusion, again, of this 5% rate increase in each year of the biennium. Or, like I've mentioned, 1% additional increase in the first year and 5% in the second year. Again, we really want to ensure that these rate increases support increases in wages to direct care workforce. However, we know provider agencies have not gotten the necessary reimbursement and rate increases in a number of years, and that it's necessary for these providers to get that additional funding so they can support their workforce. For DRO, we're going to be going a little more expansive in our advocacy. We, of course, are supporting the coalition and their ask. We want to see a reinstatement of the nursing home bed buyback program. We think that's really important in ensuring that the service system in HCBS is fully supported. And that there's parity there, that people actually do have an option to live and be supported in their home and communities. A reestablishment of the wellness funding as a standalone program that provide more flexibility to support students with disabilities, and an increased investments in multi-system adults. So what it is that the coalition will be doing, which we've done this whole budget, is, and I pulled this just from one of our coalition meeting slides, but this is essentially our advocacy moving forward. We're hoping individuals within the coalition call and meet with their senators, talk to them about the percentage rate increase for providers. We send out action alerts pretty often recently, about once a week, letting everyone know opportunities to testify, write letters, talk to their senators, etc. We're also very engaged on social media. So I realized I forgot to put both of our social media tags on here, but the coalition does have both a Twitter and a Facebook page that's been very active and engaging individuals on social media using the hashtag #BetterAtHome. This is a picture of our website front page. Across the top there is like a home main menu bar. On the very right-hand side is the Contact Us button. If you want to get more involved with the coalition, you can go to ohiohcbscoalition.org and go to the Contact Us page. I think Sam is on here, so maybe Sam can put in the chat box our social media tags as well if you want to follow us on social media. And this is my contact information. Like I mentioned, there are a number of us on the steering committee for the coalition, so you can contact a number of us. Also, if I got anything wrong, if any of the steering committee members are on here, please also feel free to speak up. But you can always reach out to me at my email. That's the best since we're still working from home if you're looking for more information on the coalition. And I just have one final page. I am going to be sending these slides to Kelsey to share with everyone. These are just sources. At the beginning, I provided a lot of data, so I wanted to make sure that you all had access to those sources if you wanted to pull out that research as well.
Jordan, thank you so much for your presentation. Lots and wearing two hats for DRO and the Home and Community-Based Services Coalition. Whew, take a drink of water, my goodness. So we have plenty of time left over today for questions, comments, concerns. I'm sure, I know Soley and Jordan and I could talk forever about what's all happening at the State House and really kind of the general, just what's happening in the budget. It's such a crazy time. One question I did want to just to kind of make clear, because I know both Soley and Jordan, you talked about rates for providers. So something that has always kind of gotten me talking about who sets those rates. And, you know, given that many of the providers that, you know, provide such great care and services for those folks who need it are on these programs themselves. If you could just, both Soley and Jordan, or either, and add on, talk about who sets those rates and kind of who has the power to change them.
It's all you, Soley. Go ahead.
Yeah, so there's so much to talk about with this. So mental health parity is a really big issue with why behavioral health providers, at least, are unable to pay better pay rates, right? So reimbursement from private insurance for behavioral health services is basically completely flip-flopped with other healthcare. So generally with other, you know, medical healthcare, you're seeing higher reimbursement rates from private insurance, and Medicaid is usually like their write-off, right? But it's actually the opposite for behavioral health. So typically for behavioral health providers, Medicaid is the highest payer, and private insurance sometimes pays half of what they pay, while at the same time requiring a higher license to deliver the same services. So you're requiring, you know, more costly providers essentially, and reimbursing significantly less. And since the Affordable Care Act was put into place, more people have insurance, but more people have insurance that they really can't use. So they have these high deductible health plans that you really can't access your benefits until you've hit a really high deductible. And so it just, there's a lot with private insurance as to why, at least in the behavioral health space, mental health parity is something we've been working on as a group for over a decade. And so, you know, we had some success with that last GA, getting some provisions and updates to Ohio's code to match with the federal MAPIA legislation, but there's still a lot of work to be done in terms of the actual accountability of private insurance plans to reimburse at a better rate for behavioral health services, to make sure they're not putting prior authorizations, fail first kinds of methods into play with behavioral health services. So honestly, a lot of behavioral health providers, you know, the Medicaid rate is what they're banking on, but we haven't had significant increases in the behavioral health space, excuse me, since the BH redesign. And really, I mean, we had a few targeted increases in certain rates for that, but it essentially was to make sure that services could continue to be provided. So yeah, the rates are part of the reimbursement rate, right? You can't pay someone if you can't in turn make that money somehow. So that's a piece of it. I think the other piece that is always difficult is that benefits are such a huge part of payroll for providers, and those costs are always increasing too. So there's a lot that goes into it, and that's specific to behavioral health, but that's going to be for most providers, right? If your reimbursement rates are low, you can't recoup that revenue to pay people or give increases or what have you.
Jordan, anything to add?
basically the same, right? Medicaid reimburses providers and our service systems as well. The bigger difference, I think, from the mental health system versus ODM and ODA and DODD administered waivers is they have waiver programs. The mental health system does not have an HCBS waiver program. So, you can apply for a 1915C HCBS waiver is what it's known as. There are some states that have a similar kind of thing. The Ohio RISE program is going to be one of these waiver programs. But there is a lot more money that is available to be used in the community for providers when there are these waiver programs that are available. I think, at least from our perspective, an issue is the mental health system in the state does not have that kind of waiver program to support specifically those that we typically label as seriously and persistently mentally ill. We just don't have that kind of program to fully support them. And I think if we did, there would be, the mental health system would look a lot different. I know I'm going a little beyond the question here, but in terms of who, sets those rates, it is in large part the General Assembly, right? The General Assembly determines how much money goes into these systems. Last budget, they set specifically a wage increase for DD, direct support professionals. So they do have a really large scale authority over here, which is why we as a coalition have been putting so much focus on this specific budget, because they do have the ability to provide additional funding to our service systems.
Fantastic, thank you both. A couple questions from our audience here. So both Jordan and Soley, you mentioned Ohio RISE. How does the new Ohio RISE program coordinate multi-system youth and multi-system adult programs, if at all?
Yeah, so Ohio RISE is really specific to those multi-system youth and their families. So their families may not be part of a multi-system. So they're kind of two separate populations, if you will. So when we're looking at multi-system youth, and honestly, the Department of Medicaid and Mental Health, they're still working through the rule formulation for a lot of this. So some of these definitions aren't final yet. But when they're looking at multi-system youth, they're looking at, complex behavioral health needs, complex medical needs, justice involvement. So they're looking at it from a variety of ways, because essentially the goal of Ohio RISE is to keep children with their families, right? Is to not do out-of-state placement, is for kids who are at risk of out-of-home placement due to whatever their issues may be. If it's, behavioral issues that have then turned into justice issues, or if it's just the cost of care that is preventing people from being able to keep their children in home. So that the children are the focus of that program, but their families are involved in services as well. The multi-system adult is really, and again, this is something too that the department's still working on the actual definition of these in rules, so we don't have them specifically, but I've been involved in those conversations also, and they're looking at, people with severe and persistent mental illness that are also veterans, people with severe and persistent mental illness that are involved in, court, legal, continuous and like in and out of medical or emergency rooms. So they're really kind of looking at a broad definition, and in the behavioral health space, at least, especially with kind of both groups, we all have patients we can identify that we're like, yes, they would benefit from something different, something else. So those two populations are kind of separate, but I do want to note that Ohio RISE certainly does include the family members of those youth involved, but the youth is the identified client, if that makes sense.
Thank you, Soley. This one's coming up for Jordan. Can you expand more on what hospital licensure is and why it's important to behavioral health and DD issues?
Sure. So I don't think I mentioned this when I was giving the presentation, but Ohio is the only state without a licensure program for their hospitals. Every other state licensed their hospitals through their Department of Health. We do not. So it became, I think, a large issue during the pandemic when hospitals were taking a brunt of individuals who were who had COVID-19. And there was a fear at the beginning that they would have to start rationing care. So determining which individuals would get, like ventilators and those kinds of things. The nationwide fear was that that would be a discriminatory practice for people with disabilities, because there is an ideology that people with disabilities have a lower quality of life, and that these ventilators or other services should be given to other individuals that don't have disabilities. That is clearly discriminatory, right? And so there were a number of states who were actually doing that, and a number of P&As and a number of organizations actually sued individual states because of that. Luckily, Ohio never got to that space, but I think the issue we saw was the state really didn't have an authority to create a set of guidance or rules that would require hospitals to not ration care based on disability. The closest we got was some guidance, and we got additional guidance in conjunction with Medicaid and DODD and ODA. However, that still was not an official rule, right? That was not something that could be enforced on hospitals. And so really what we have seen is each individual hospital kind of sets its own care rationing guidelines. And it's very difficult for any one organization advocating for individuals to really be able to go into each individual hospital and say, hey, you can't be doing this. And it's also very difficult even to go through the hospital association, because even as an association, they don't really have authority over their hospitals to tell them what they can and can't do. And so it was also difficult to even go through the association to work with individual hospitals, because the association didn't have that kind of authority. So essentially, what's the most necessary step is ensuring the state has the authority to license these hospitals so that they can set up these kinds of rules and guidelines and put into place these kinds of criteria for hospitals so they don't ration care. Obviously, it's kind of late at this point because we are, slowly the vaccinations are rolling out and we're coming to what hopes to be the conclusion of this pandemic. But it's still necessary that the state have this kind of centralized authority so that people can be better advocates for those who are in hospitals and ensure that individuals aren't being care rationed.
Anything to add, Soley, on the behavioral health front?
I mean, we are very highly regulated and certified, which is always good because that helps ensure quality. So, we don't have a specific stance on this issue necessarily, but do understand the operational, logistical, and honestly quality assurance pieces that licensure can help with.
And truly, it kind of blows my mind that we don't. Jordan pointing out that we are the only state that doesn't. We license everything. There are quality controls. There's, authority above so many other providers and different structures. Very interesting. Very interesting. Thanks for sharing more about it. Next question. What do you think we'll need before the Ohio legislature will start to fund home and community-based services at a higher and commensurate rate than nursing facilities?
Maybe I'll start with a candid answer, and that's political willpower and maybe campaign donations. Nursing homes are a very powerful lobby in the state of Ohio, and they have been very good at getting the legislature to continually pump money into that system. I should be clear, we as a coalition are not advocating against nursing homes or institutional care. We actually have nursing home groups in our coalition. We're simply advocating that the state provide essentially parity, right? That people can have access to home and community-based services, because currently right now, That's just not the case. People are forced into institutions all the time. We see this every day where people cannot access a direct care professional in their home. And because of that, they are forced into a nursing home or some other institutional setting. So our hope as the coalition was that this large collective voice would kind of push the GA to see the need to increase these investments. Obviously, in terms of House strategy, we were not as successful as what we had hoped as a coalition, but we do have some hope that in the Senate this will we will be able to get those kinds of increases. However, I am very pessimistic about this because in terms of, historically, our service systems, mental health, DD, they have just not been, and aging have not been fully funded and supported by the General Assembly. And so this isn't just like something that's been occurring for the past 5 years. This is decades and decades and decades. Ever since the deinstitutionalization movement in the 60s, there's just never been the support to the community. And so we're trying our best with the coalition, and we hope this does something, but I think at the end of the day, we just don't have the kind of political force that nursing facilities do in the state of Ohio.
Well said, Jordan. I know that's been a frustration of so many, you're right, for decades. It's really interesting. I know AOF and other organizations, I'm sure both of yours as well, are very intentional about how we talk about not even just kind of the humanity of the services that we talk about, and really the necessity to make sure that people have a quality of life in our communities. But we have to talk about it in terms of return on investment. We have to talk about what is the deal that the state is getting for investing in these services. So I know we've had to change the way we talk about really vital kind of human rights issues and care on more of in a different kind of set of vocabulary, such as return on investment and other kind of accounting and less warm, we'll say less warm and common sense terms, but hopefully we'll get some takers here soon. So I do see another question here. We have a few more minutes. Can you explain more about why the student wellness funding shouldn't be added to the main funding formula? I know it's unclear. So right now it has been rolled into the main funding formula. The governor proposed it to be separate. It's been separate in the past. Can both of you talk about why it's important to pull that out?
Yeah, I can start, and then Jordan, feel free to add in. So essentially what happened is they moved that funding into that disadvantaged impact pupil aid that I mentioned. And that funding is allocated based on poverty levels for school districts. So the student wellness and success funding had like a base level amount of funding for each school. And then there was additional funding depending on some of those economic indicators for each school. But so this funding, essentially some schools could not get any funding for this anymore at all. And to us, it's a couple things. And this certainly, I think, is unintended, but this idea that behavioral health or mental health kind of prevention or services is tied with poverty is very stigmatizing. I mean, prevention, behavioral health services are good for all. And really, if you look at the school wellness and success funds, the way it was set up initially really ties in very well with ODE's whole child initiative, right? So they have this initiative to treat the whole child, regardless of background, impact, what have you. And so being able to bring those services to all children and all schools is key in our opinion. And so the way those funds were set up initially lends to that. The other thing is the student wellness and success funds, the way they were set up initially, there are about 10 different services they can be used for, right? So behavioral health, integrated care, there are a bunch of health-based or health-focused initiatives and services that schools can use those funds for. So this disadvantaged impact pupil aid funding has about 25 different items that it can be used for, and it runs the gamut. It's like school safety, which is then going to get into like school resource officers, and really competing with other things that are certainly a priority, but may not prioritize mental health anymore, right? And so there's no guarantee that any amount of that funding will be used for behavioral health, mental health, prevention types of services.
Anything to add, Jordan? Interesting. I always learn so much on these. Did not realize that the expanded uses of those dollars had grown. Wow, very interesting. That's a huge range, and you're right. The priorities will certainly shift with those additional uses. Goodness. Interesting. So as far as kind of your conversations in the House, in the Senate so far, is there an appetite among legislative leaders to pull those dollars out? Are they, I'm sure they're listening, but, are they making those connections? Do you think that we'll see a change when the Senate comes out with their next version of the bill?
Yeah, so we've had some good conversations, and certainly the ability to point to, we want to make sure those funds are used for behavioral health. I think a lot of the senators like that it had a specific use and could be used for a specific thing, because essentially it will be unrestricted if it's through those other fundings and goes through the way it's set up now. So we've had some good initial conversations. We're working with a stakeholder group that we're a part of to kind of put out a formal stance on our ask that I mentioned, that, we just reinstate the student wellness success funds as proposed by the governor. So we are certainly doing work on this, and have had some good initial conversations, and hope they see the value in leaving them as they are to be able to reach more students, because ODE put out a report on the first year use of these funds a few months ago. It might have been late 2020, but they certainly have been used, and I think it was about 67% of the funding was used specifically for mental health initiatives. So we are certainly invested in seeing these funds kind of reverted back to the as introduced budget.
And I know there's also a chance that the whole school funding formula will get pulled out of the budget as well. So that would just continue the conversations. I know everybody, we need more time to talk and plead our case, but anything could happen. So stay tuned. We'll be back every other week to give you the scoop. Jordan.
I was actually just going to say exactly what you said, which is, I think, we've heard the Senate president and the Senate generally have a different idea of what school funding should look like from the House. So the odds of it staying in its current form, I think, are really low. But I think there have been some discussions about keeping parts of it in. It's just determining which parts of it are going to stay in. We have had a few conversations with members about the wellness funding, and it seems there is growing support to continue to keep that as a standalone. I know a number of members have talked about, we don't have to tie everything to the school funding formula. We can keep certain things separate. And this is one of those programs that I think there is an appetite to keep separate indefinitely, because it is just a very effective program in its current form. And it's not going to be nearly as effective tying it to the disadvantaged pupil impact aid.
All right, folks, I think that will conclude our webinar today. Soley and Jordan, I want to thank you so much for your time this morning. Always enjoy the chance to speak to you, and are so happy and proud to have you as AOF steering committee members. And man, what an exciting time. We will continue to keep a close eye on what's happening in the Senate. We do expect a new round of changes coming out probably mid-May, and we'll be here to report that to you and also talk to you about different opportunities to get involved and make sure that your voice is heard in this process. With that being said, folks, thank you so much again for your time and attention, and we will see you in 2 weeks at 10:30 for a discussion on the American Rescue Plan. Thank you so much. Have a great one.